Low AMH levels, the one thing that is shattering the dreams of so many women. The dream of starting their own family. Today, we are not going to talk about what should we do to improve the AMH levels, what foods we should eat, etc. etc. Today, we are going to talk about will low AMH even matter to your dreams of having a healthy pregnancy? Is IVF the only way if the AMH levels are low to conceive and have a healthy pregnancy? To talk about all of that, we're going to have Dr. Sunil Ishwar with us. He's the one who puts people front than profits in his practice. He's the one who recommends what is absolutely right for you and try for natural conception. He's a lead fertility practitioner at IKEA Fertility Center and iMumz Fertility Center in Bangalore. Today, we're going to candidly discuss what is going wrong with couples who are trying to conceive and what is going wrong from the side of care providers and why we as a society we have kept low AMH levels as a badge of honor for the fertility levels. So this podcast, rather than explaining something new to you, is going to make all of your myths about conception. Please watch this till the end. We have attempted to talk things as boldly as we can to give you the right informed decision. AMH levels, it is a topic of discussion. And many people are measuring their AMH levels who are trying to conceive and also worrying about it too much. So today we want to know all the myths. We want to break all the myths and want to know the reality about AMH. But firstly, sir, please tell us what are AMH levels?
Okay. So when you talk about AMH, the full form, let me tell you, it's Anti-Müllerian Hormone. It is present both in male and female. Especially we're measuring this in women. To know about what is called as ovarian reserve. So there are two ways to check ovarian reserve. One is by doing an ultrasound, by a transvaginal ultrasound, looking at the smaller follicles and the volume of the ovary. Not just the follicles, because not every time you will have all the follicles ready in the ovary. So smaller follicles and the volume of the ovary. Next is a biochemical test, which is by test called as Anti-Müllerian Hormone, AMH. It is secreted by the smaller eggs, which are not very small but not very large. So it's between 2 to 4 mm kind of size of the follicle. Secrete this chemical called as AMH, and this is measured in the blood. Any time of the day it can be measured. Any time of the cycle it can be measured. And it's not that full stomach, empty stomach, all people tell that, oh, you should have done it in the morning or in the evening. Nothing like that. Anytime it can be done. It is a constant one for that period of time or cycle. Then the question is, how relevant is this test? We always tell this as a one dictum. Whenever you're doing an AMH, you should always look at the scan when you're doing a AMH test, because these two have to correlate. One test should not be read separately from the other. I would give more importance to antral follicle count than on AMH itself. But if a patient is or a woman is planning to have pregnancy after a year or so, or after some time, then she wants to know what is her probability of waiting longer, then AMH works. But when you're trying to do a fertility treatment, then AMH is not the most strongest in predicting the outcome of pregnancy or whether it's going to happen or not in this cycle. The most important thing at that time would be probably antral follicle count, that is the follicular count. So I would always suggest even when we do get lots of doctors coming for training, we run our own fellowship program. I always tell them this one thing. When you're doing a test for ovarian reserve, always look at both AMH and AFC. Do not give your verdict just looking at one and say, oh, this is wrong, or this is this way. Because we are trying to build confidence in patient, not to scare them, right?
Yeah. That's a very good point, sir, building confidence. But today, many people, like I'm a layman, and many couples are also understanding, low AMH means low egg reserve. Everyone's born with same set of some fixed number of eggs.
Correct.
So low AMH means low egg reserve. Is it true always?
Now there are different stages in life where AMH can be low also. Before the woman becomes reproductively active, I would say menarche. Before menarche, AMH is going to be a little bit on the lower side, and very close to the menopause, it's going to be low. And there are other certain medicines also which can make the AMH low.
Okay.
So, as you said, AMH being low has become one of the curse in the modern society of fertility treatment is what I would call. We have seen quite a lot of patients coming with AMH and telling, I've done an AMH test and I've been suggested to go for an IVF. I've done an AMH test, I've been suggested to go for a surgery, like that. Let me tell you a few things about how do I look at AMH. As you rightly said, it is a test for ovarian reserve. So that means you're talking about the future. Right? We are not talking about the present. Present hai jo dikh raha hai, and whatever we can see in the scan, we can see. That we can always tell. But AMH is telling something about future. How long can we wait? How long this reserve is gonna last, right? AMH, once it becomes when we get it on the lower side, we've also seen patients coming with multiple reports telling once my AMH came low and now it is high, then again it came low. So these kind of reports. That's why I said always read AMH with your scan. When you have two variables correlating together, then it's very unlikely this variability of high and low is coming. When you talk about low AMH, then I would divide it according to the age now. If you're more than 35, you're less than 35, and you're less than 30. If you're less than 30 and you have a low AMH, many texts says 1.6, some say 2, some say 1.2, but according to the definition, mind you, it is 1.2 is the cutoff. But this is defined in the terms of when you're taking a treatment for IVF.
Okay.
Not in terms when you're trying for a normal or when you're trying for an IUI. So anyone who is at less than 30 years of age with an AMH of less than 1.2, I would still suggest them to try normally. Because you're not going to run out of these eggs in next 2 or 3 days. 2 or 3 months, right? Next is anyone between 30 to 35. Now these people need to be monitored well, because anytime the tilt may happen. Why again I am talking about the age? I will come to that later.
Right.
So in this 30 to 35 age group, I would suggest both. If you have time, try normal. If not, go for a treatment called as intrauterine insemination. That is also gives us a tremendously good result. Now next age group is more than 35. When it is more than 35, I again give a choice to the patient whether they want to try normally for some time or go for an IUI or IVF. Because we know that when we go to IVF, there is a totally separate kind of a protocol which we need to follow. I'll come to that. I said age is important. The quality of the egg or the resulting pregnancy of the from that egg is totally different age-wise.
Right.
Anyone who is less than 30, even if their AMH is low, quality is still very good. Between 30 to 35, you're still in a better place. But more than 35, in an Indian scenario, I would say, the quality of the eggs go down, and your chance of having the genetic problems, aneuploid is what we call, is bit more. So that's when you need more counseling or discussion before taking any kind of a treatment protocol. Next is AMH in relation to your particular choice of treatment, particularly as you said, IVF. I'm not against IVF, I'm telling you, because we are in this treatment protocol, or we have an IVF center too. See, when you talk about an AMH which is low, and when you're talking about IVF, IVF is totally determined, the success determined by two very important things. One is the age. Okay. Next again is the age. Success of IVF is determined by the number of eggs and the quality of the eggs. Quality is again determined by the age, right? So number of eggs. When you talk about AMH which is low, then you know that the eggs are going to be less. Now let's take an example of someone who is at 35 years of age. If you put it, I think there are lots of softwares which will calculate and tell you how many eggs you need to, achieve a success of 40% or 50% or whatever outcome it is. So roughly at age of 35, if I want to have a good pregnancy outcome, we say around 50-60% still possible. Only if you get around 10 to 12 eggs. If you get 10 to 12 eggs, we are able to form around 5 to 6 or 8 embryos. Out of these 5 to 8 embryos, maybe 1 or 2 will be euploid or genetically good.
Right.
So when your AMH is low and you've been suggested to go for IVF, now you can do your mathematics yourself.
Yeah.
You are seeing only 3 or 4 eggs and you're telling go for an IVF and I'll give you an outcome. How will it happen? That's when we say you need to look at different protocols which will help you. But before going for this, understand that your natural cycle or an IUI needs only 1 or 2 eggs.
Right.
You rather explore that option before going to IVF. Ultimately, if no options are left, IVF has to be done. But AMH was particularly devised to say, measure 2 things. One is ovarian reserve to counsel what kind of treatment can be an option. And AMH was most devised or used only to tell as to what can you expect when you try to do an IVF in this patient. Not to tell that if your AMH is low, go for IVF. It only tells if you're going for an IVF with an AMH low, what can you expect?
But today, sir, practically, like we are saying, there is one couple who told us they had 0.3 levels, 0.3 as an AMH count, and they are 35-ish, both the couples are. And the first thing the doctor told is immediately you have to come and do an IVF. We have to start the procedure. In less than a week, we have very less time.
No.
What do you say about that? This is something practically many people are facing as well. Because your AMH levels are low, you have to go for IVF only. What is the thought process 100% accurate, or what should couples do in that point of time?
Now, I again and again want to reiterate this point that AMH is not a value or to be used to decide the mode of treatment for fertility. It is only to prognosticate your outcome when you go for this fertility treatment, particularly IVF. AMH 0.5, I am going for an IVF, I can expect this is the result.
Okay.
Not that if it AMH is 0.5, you have to go for IVF. Sorry, that's a very, very wrong concept. Probably this has been very nicely sold because it's a fear now. You know, if I tell that, tomorrow this is going to happen to you, you do something now so that you can avoid it. You would rather do it, right? So that's the simple thing. I would say this is how our all that lots of misconceptions or myths are around. If a cat has crossed your road, don't go there. Wait for 2 more vehicles to go, then go. So those kind of, it's something like that. I would say it's a biggest myth. People are selling this AMH as like, okay, if AMH is low, go for an IVF. But question is simple. What prognosis do you have? If I say 0.5, what do I have chance what chance do I stand if I go for an IVF? It's not for, if AMH is low. So like, as you put it across, we had a similar couple, Northeast couple, who were in the 40s actually. Obviously, we expect AMH to be low. So they were suggested IVF straight away. We said, give us 3 months time. You just try normal things, you try whatever you time, because in 3 months, it's not going to be drastically low. I'm seeing 3 follicles. Tomorrow, the next month, I may see 2 follicles. It's not that next to next month, there are no follicles at all and, your ovaries have decided not to work. It doesn't happen like that. There's a gradual depletion of this number of eggs. Until unless you have undergone a surgery, you have some autoimmune disease, or you have some kind of genetic predisposition which is, eating away all the eggs. But in those kind of cases, we know that this is happening faster. There are very, very less incidents of these kind of cases. If I see around 100 low AMH, maybe 0.5 to 1% will fall into this 3 or 4 category. Rest of it is naturally it has come down to below. So this couple were just advised, and fortunately they conceived. And there was one more couple who has undergone all the treatment, IVF also done, and AMH of 0.1. We said, okay, we may also have to go for an IVF, that this is our protocol, wait for 3 months, we'll put you on certain, the rejuvenation or antioxidants and lifestyle changes, and positive reinforcement. And fortunately, she conceived, though it is not good for our business. If you look at like that, because IVF is a huge money, but then if you conceive naturally, neither I get a credit or
so people important than profits. There are people like you who think that way.
Of course.
Yeah.
Because it reduces our burden of answering to you also, right?
Yeah.
So that's one thing. So we have had quite a number of patients with low AMH who have conceived. We are particularly not very scared, or we do not try to instill this kind of a fear in their mind that your AMH is low today, tomorrow we will be starting your protocol. You understand that this is where we are. First thing is you need to understand, okay, this is the amount of time which you have, or this is the number of eggs which you have, and how can we circumvent this to reach to the goal of a pregnancy and a baby.
That's very beautifully said, sir. I think this is very important for couples who are trying to conceive to understand this, because there is a very natural fear response. On that note, I want to ask one more question. Today, when we speak to so many female partners, they get shattered when they know that they have low AMH levels, and they always associate that number as some progress report, that this is what my fertility index says. So
No.
for a layman, when they get to know that they have low AMH levels, what does that mean? I mean, okay, let's say I have 0.5 AMH. What does that mean to me? What does that indicate? How can we help them understand?
See, first thing is, I think there are lots of software or lots of calculations which talk about fertility index and things like that. Working for almost 22 years in this field, we've seen lots of things happen. However good your data or system calculation or your AI is, you cannot say that this patient can conceive or cannot conceive.
Right.
Until unless I tell, okay, you don't have a uterus, you don't have ovaries, you don't have tubes, you have nothing, then obviously you can't conceive. That's a totally different situation. But as long as uterus is there, as long as a healthy functioning endometrium is there and the ovaries are there, they're going to conceive, right? Next, which is most important is, now I've, this is also, sometimes we keep laughing at this, patient come and ask, sir, doctor, my AMH is 0.5, as I said, and the other doctor or whoever has told me that I have only 20% chance of conceiving. Hi, Ravi, you tell me, have you seen anyone who has conceived only 20%?
Yeah, I mean,
they conceive 100, otherwise 0.
It's binary.
Right? So it's just a number which instills that. Because we are all in society which is driven by the numbers where 90% is what everyone expects, 99%. Then I will tell that same patient, I will give you 99% guarantee that you will conceive. Can you tell me who is this 1% who is not conceiving? Can I tell that it is you or anyone else? No, right?
Right.
I can't tell that it is your everyone. I will say 99 conceived. Unfortunately, you are the only one person who has not conceived.
Yeah.
Will you buy that? No.
Yeah.
Now let's look at what you said of 0.5. As I said, yes, there is a sense of urgency that there has to be a pregnancy because your AMH is low. When it is going to become very low, we do not know. There's no demarcation as low, very low, extremely low. There's no categorization like that. If you're a young patient, less than 35 years of age, even with a 0.5 AMH, we have a pretty good chance of trying normally or with IUI. And yes, if we have to go to IVF also, there are certain protocols which you need to understand. It may take a little bit longer, but still it may happen. Anyone more than 35, we also, in them also is the same thing. But yes, we tend to go towards IVF a bit more in their case. Reason is simple. As I said, the chance of genetic abnormalities or genetic outcomes are pretty high with them. So we generally suggest them to go for IVF with some amount of genetic testing if they can afford to go for it. Yes. We have also seen patients who are, in spite of undergoing IVF, have conceived naturally also. So keep your hopes positive.
Sir, again, follow-up question on this. I want to talk from the point of view of a couple, those who don't know anything about all of this. They were just told that your AMH levels is 0.5. Now, does it mean that lady has egg reserve for only 6 months, 1 year or some amount of time? Or does it mean that quality is low? What does it mean? How should she take that number? How should she associate that number to her fertility health? Because many people today are thinking that is the only number which will tell how fertile they are.
Yeah.
So here there is, I mean, this number is putting a lot of pressure on people. So can you please
Okay. No,
leave that burden from...
You're wondering why I'm smiling. From
Yeah,
that.
yeah.
Let me tell you this. Okay. You would have seen many of our, particularly our Bollywood movies.
Yeah,
I think
yeah,
where they go to the doctor and they say,
Yeah.
आपको कैंसर है, only 2 महीना बाकी है,
Right.
और 1 महीना बाकी है.
Right.
We are like, oh my God,
Right.
such a
Yeah.
brilliant diagnosis and treatment.
Yeah.
Or you will see some surgeons coming out of the OT and say success.
Yeah.
Well, this is actually, as when you said, I've got a 0.5 AMH and now my fertility index, and this is what is the chance of your conceiving. I think I've already told you, please don't concentrate too much on these numbers. When we talk about this number, this is only on the background of an IVF. If you look at the literatures, you do Google search, or you want to go and ask your chat GPT, probably the better answers you may get over there. I do not know. I have not tried chat GPT. So, but this is not an indicator for which kind of treatment you have to take, how much time we have, because we know there are certain patients who have 0.3 AMH 2 years back, it's also 0.3 now. So will that mean that that egg reserve has been the same? No, it is reduced, but it's only that it is not showing up in the report. What I said is, if I'm starting a treatment today, I would depend more on the number of eggs which I see.
Right.
So no patient should get discouraged or go by this terms where many patients of us who go to other treatment and come say, sir, the doctor said that I cannot conceive. That is one of the biggest lie, I would say. Until unless you've not had a uterus, that's a different thing. As I said, there are only 2-3 situations where we'll say you will not be able to conceive. Other than that, anyone or any woman should be able to conceive. Another thing about AMH, Ravi, as I said, there's not much of a variation in the time when you do this test, be it the day of the cycle or the time of the day. But we have also seen there is a lab to lab lots of variations.
Okay.
So we need to be a little bit cautious about that also, because there are lots of fly-by-night kind of labs which are there. And the report variations are definitely there.
That's interesting.
And we've also seen if the patient is on any ovarian suppression treatment, or she is on oral contraceptive pills, long duration of oral contraceptive pills, or on any other medications. I cannot elaborate all the medications which can interfere with the ovary function. They will wrongly come up as a low AMH. But I'm very much concerned about the lab variations, basically because of there are so many labs which have been there in the country which just are not certified to give the reports, but then they are giving it. So that creates more of a confusion, or probably that has put more fear into the people's mind.
Yeah. So this is super insightful. I think nobody's speaking this harsh truth. So is it safe to tell AMH levels does not conclusively tell anything about how much time the couple have for natural trial, or how much time the egg's going to last, or quality?
No. This is safe. You can openly tell. There is nothing like this written in any book telling that if your AMH is low, then you have only I will tell this is the time. Itna time baki hai.
Right.
No, nowhere. And again and again, in the books or in the research, we have seen that AMH does not talk about quality at all.
Right.
It does not talk about quality of your eggs at all. It only talks about your reserve. Right? Number of eggs in the future, what I will be able to get if I do an IVF stimulation with you. If you have 0.5 AMH, if I do IVF stimulation, maybe I get around 3, 4 or 5 eggs or 6 eggs, but not more than that. That's all it talks about. It does not talk about quality of the eggs, does not talk about how you are going to achieve pregnancy with this kind of eggs. As I said, age is the most important thing. But there could be one more thing. What could be the reason why your AMH is low?
Right.
That can impact the quality of the eggs.
Right.
Not the AMH, your constant value, or your quality is most of the time depend on the age and your genetic factor. Nothing to do with AMH. No one can predict. Probably one more person can predict this. Where you go and get your Jatka written, whether this marriage is possible or not.
Yeah,
Because many times when the patient come and tell me all those things, I was like, before marriage, did you ask your astrologer when did he predict your child is going to be there? So something like that. This is, I would say there is a science, the way to tell it.
Yeah.
Right? But AMH itself is not a verdict.
Right.
To tell you can conceive, you cannot conceive, you can only conceive in next 3 months, and this is your quality of life. All these 3 has to be, or 4 has to be dismissed.
Yeah. Brilliant, sir. I think this is quite insightful. Now, another question I want to ask. Many times doctor says your egg quality is low.
Yeah.
What do you mean by that? Like egg quality sounds very abstract to people who are trying to conceive. So in a layman term, what someone should understand when doctor says egg quality is low?
First of all, egg quality can only be determined when we take that egg outside your body, examine it under the microscope. So that is only possible when you are doing an IVF treatment, not when we are doing a normal or something. Next thing, when we are doing a scans or when we are looking at the ovaries, we are looking only a fluid around an egg. Egg will be small, very small spicule, maybe less than a millimeter size. So we will not be able to see that when you're doing a scan. So scan is not a way to tell, okay, your egg quality is low or bad. We can do some blood tests to see how well that ovary is functioning or the egg is functioning. But still, that is a way far surrogate marker to tell about the quality. Quality of the egg can only be told by looking it under the microscope. Right. Next is, when you do a IVF stim and we take the eggs out and we examine under the microscope. Even when I see around 10 eggs, not all are same quality.
Right.
Okay. Some will be good, some will be granulated, some are large, some are small. So on an average, you will find, even if it's less than 30 years of age, you will find 1 or 2 eggs which are not really good.
Yeah.
So you cannot justify that, your AMH is reason for low quality of egg, or scan wise I saw your eggs are not good quality, because I know where you're coming from, because some patients would have told you, sir, they have done scans and they're telling my egg quality is not good, egg quality is not good.
Yes.
No, you have not seen the egg. How can you tell about the quality? When you're not seen a thing, how can you tell about its quality? If I've seen the egg, I will tell. Even then, if egg quality is not good, the only way to tell that anything, the quality is not good or bad, is if it doesn't result in a pregnancy. Correct? But when you're trying a normal or an IUI, there are many reasons why the pregnancy doesn't happen. So it is a very, very wrong way. Probably, we have gone a little bit way too ahead of, thinking. Sometimes we kind of extrapolate things. By just looking at the growth of the follicle, we'll say, oh no, this follicle is not growing well, so the egg quality is not good, which is also wrong.
Yeah.
By looking at the scan, we sometimes do not see good amount of blood flow in that, and then we'll say egg quality is not good. As I said, these are all surrogate markers, but not necessarily the reason. Right. Until unless we look at it under microscope, we cannot. And egg to egg, there is a difference in the quality. Another thing I don't know whether you would, because we come across this, quite often, and it is really inhuman. It's probably, and I do not want to use those kind of words. You've seen many patients undergoing IVF stim in other centers and coming and telling that, okay, I've been suggested to go for donor IVF program because my egg quality is not good.
Right.
Okay. Now, when you're doing an IVF stim, egg quality, yes, definitely the outcome depends on the egg quality. When you're doing an IVF stim, we get those eggs, we examine the eggs. Can you tell me the reason why your egg quality is low? First thing, when any doctor says, my patient or our patient should ask this question, why is my egg quality low? Because there's no firm answer to that, because until unless I gone into a genesis of the egg and how it came and what happened, I will not be able to tell. I can only tell you what are the reasons for egg quality being low. First is genetic. Next is you're born with you're born with certain amount of genetics which has resulted in the egg not growing properly. The receptors are not come up well, so that's why the quality is not good. Okay. Your lifestyle, stress, your intake of some other medications, blah blah, lots of things. Basically, lifestyle can also be a reason for your egg quality not being good. Cycle to cycle variation is there. What batch of egg come this cycle is different from what it's going to come next cycle. I just say can you tell that in a class 1, if you have students now, will be the same after 5 years also the same, or next batch also is going to be same? No. Your students keep changing. Your same school, so that's how it is. Your eggs also change, cycle to cycle variations are there. Next, which many of them would not agree, is that your stimulation protocol. Because I do not want to take the blame. So I would say your stimulation protocol also is a reason. The dosage of medicine which is. You've seen that if you use too much of high dosage of medicine, the quality goes for 6. Too long a protocol, too long of the cycle, you're given for 12, 13 days of injection, your quality may go down. Okay. Then next, which is probably not in our control also, is storage of this medicine. Because we use very highly purified, or we use recombinant injections. It is manufactured in one place, it gets shipped, comes, storage, and then it comes to us. Okay. So in our center, what we do is when we take a batch of medicine, we keep a track of it to see how the patient has responded, what is the quality of the eggs which are coming out of this batch of medicines, and then we say, okay, this batch is good. Because we have seen batch to batch, there has been variation in the way the eggs come up. So sometimes we have even seen that 3-4 patients back to back the quality was bad. And when we cross-check, there was associated only with this batch of medicine. So this can happen. It's not that everything is under our control, right? So we've seen quite of this happening immediately post-COVID also, maybe because of storage, maintenance, everything. So when you talk about egg quality in an IVF stim, these are the things: your genetics, your cycle to cycle variation, your lifestyle, and also the stimulation and the stimulation medicine. Just by one cycle, please do not dismiss this patient of telling your quality is bad and you need to go for a donor.
And that is very hurtful when they hear that, oh, I can't give birth to my baby with my own egg. That is quite painful for a aspiring mother. Thanks for clearing that, this sir. And I'm surprised after hearing this, how come some folks are saying, without even putting it under the microscope, that egg quality is bad?
We are Indians, as Indians, we are very good in extrapolating things, I would say. I guess if this is it, then this probably should happen. So, I would, until unless we have very sound, testing method to talk about the egg non-invasively, we should not be talking about the quality of the eggs. And ultimately, even a bad egg can sometimes give a good pregnancy outcomes. See, what we say is the fertilization and the division of the the cells is a big leveler. It levels lots of things which are not under our control. Probably we thought, okay, it may not happen because nature has its own way of cleansing. Right? So we all believe in that. That nature can take care of itself. If it's so really bad, nothing will happen. If it's a little bit average also, sometimes the whole process of fertilization, division and formation of embryo clears these things and you get a beautiful pregnancy outcomes.
Right, sir. One more question. This is, I think, the problem of the generation. Okay. Practically, this generation can't give birth at 25 years. Which is probably biologically at peak considered by many doctors. Right? Everyone have their own career aspirations. People are not ready to settle soon. Like everyone has their own priorities in their life. Now let's say couple are aspiring, either they're married or they want to marry at some point of time, or any single aspirational female partner, she want to conceive at later stage of life. Now they are also going and fertility clinics and taking their fertility tests and AMH levels, again they're measuring, right? Now how can they decide, okay, according to my body, how can they decide how much time I have? And if that is not possible, how can I decide the option of having an egg freezed? How do you suggest them, like about the future, like they're not ready today, and again people are associating that decisions with AMH levels as well. So can you clarify and help those folks too?
Well, if you're deciding on AMH, then probably you're doing a wrong mathematics there, because as we know that there are lots of touch points, data points to be taken in consideration to reach to a conclusion.
Right.
Similarly here, you're looking at only AMH, right? Tomorrow something happens, you have to undergo a surgery.
Right.
And suppose the ovary has to be taken out, or the uterus has to be taken out, or fallopian tubes have to be taken out. Have you considered that? No. Next, how is your lifestyle going to impact this? This no one considers.
Right.
Because you're telling, sir, I am 25-year-old, I'm going to come at 30 years of age. My AMH is 3 now. Can I wait till 30 years of age? Looking at just these two data points, I say you can wait. Probably because your AMH is good. Every year you can come get yourself tested, look at your AFC, AMH, and things are fine. But your lifestyle, your
That
stress,
5 years,
your stress, your weight gain, your all the factors or toxins which you're taking in as a nature can affect it.
Yeah.
As you said, one more thing you said was egg freezing. Right? That's a very nice technology which we have. But unfortunately, there are two drawbacks, or a few drawbacks, I would say. Because whenever I say two, I will be quoting third also. So let me tell you a few. One is that for us to develop more eggs, you need to give them injectables. So unfortunately, these young girls have to receive the injections for 10 to 12 days. Thing that. And egg retrieval is under anesthesia, and all this medication has its own some amount of side effects during this few days. And another problem with egg freezing is now also we say around 60-70, a very good outcome is 80% retrieval of the eggs. So you need to make the calculation as to, okay, fine, now I'm 28 years of age, so for me to conceive with this, so we will give you the number of eggs which we need to have a probably good outcome with that. So AMH is only, again, as I said, to say, okay, if you want to wait for a year or so, probably it's a very good surrogate to say, okay, fine, if things are good, you have tested it, we know that it's all fine, and then you can go ahead with it. So if you're deciding on certain factors, one is look at your age and your other factors, like do you have endometriosis, do you have any pelvic infection, are you predisposed to any kind of autoimmune conditions, all these things if you rule out, and then look at AMH, and then yearly get it tested. So that way we can say, okay, you could easily. But I cannot say at 25, I want to conceive at 30, tell me if I can wait till 5 years. No, I cannot pass that verdict to you.
So somebody who want to conceive in the future, let's say 10 years down the line, let's say 25-year-old, 30-year-old folks, they want to do it at 35 years age. What do you recommend? You mentioned about yearly checkups, right? Rather than egg freezing. So, or egg freezing.
No, egg freezing
also is an option.
Because egg freezing should be an option in that age, because as I said, the outcome is totally dependent on the age, not on the AMH, age and number of eggs. So age plays a very, very important role. If at the age of 30, if you're coming and say, no, I want to wait till 35, I would say freeze your eggs, and then probably 35 is still okay, because your eggs are still at 30 years of age. Though you have moved to your outcome is that age dependent. At the age of 35, I'm using 30 years egg, so I will fairly give a good chance, a little 60-70% chance of conceiving with that eggs which are there. At the age of 35, I would say you have around 40-45%. So it's a huge number. And also the genetic problems are more.
Natural conception is also possible.
Well, that is the thing.
It's a backup option.
Yes, it's a
if
backup.
not-
It's a backup. It's like you're not using this egg itself as the first.
Right,
it's a backup
it's a
option.
backup option.
How do you put it is, yes, you always have some kind of a reserve when
Yeah,
you're traveling a thing. You don't use that money, right? You always use whatever is there in your pocket and you try. And only if this exhausts, then you use that money. It's
Right.
about
Makes
something
sense.
like that. Yeah.
Got it. All right. When somebody come to you and you have done, they come with a report with low AMH history. Typically what you do, like you promote natural conception, right? And you do IVF only as an absolute last line of treatment. So want to understand with that thought process, how do you approach?
So first thing which we do is whenever they come with this report, first thing is try to ignore the report.
Okay.
Okay, because that's gonna skew your thought process.
Put a bias.
So we just say, okay, fine, we'll look at your reports, because we are not treating reports, we are treating you, or we are trying to talk to you or counsel you. So first we need to understand what the patients wants and what are they looking at, and what's their socio-economic backgrounds and things like that. And then age, all those things we put, and how long and what have they tried till now. Okay. So, and what do they understand from this fertility treatment? Because many patients do not even know why they are undergoing them. Today, for the fact, like patient is undergoing scans regularly and she doesn't know why it has been done. Follicular tracking is going on, but she doesn't know why it's being done. So we try to understand what have you understood from your treatment first. Okay. Then we run our own tests. Basically, our only test is to do a scan. We do a scan to look at the uterus, adnexa, and the follicles. That is a number, what we call it as anti-follicle count. Look at the volume of the ovaries, and then decide, okay, whether we need any more further investigation. Our investigations are usually directed towards the mothers or the could be mother general fitness conditions, not to on the fertility. We rarely repeat AMH. We have in our center, it's like if you have one AMH, that's more than enough. We are not going to repeat your AMH. We are only going to do a scan, because that's cheaper and
one AMH report, past
that's
report.
Anytime,
Right,
wherever you're done, it is because we per se ourselves do not, even if you're coming for the first time consultation, until unless I see your ovaries to be smaller, I see your ovaries to having lesser follicle, just to corroborate my diagnosis of a low ovarian reserve, I would get an AMH. If I see a normal functioning ovary, or if I see a polycystic ovaries, I would not want to go for an AMH. There's no point doing that test.
Right.
Okay, just to corroborate my finding, to say, okay, your ovarian reserve is low, I would probably do an AMH. Otherwise, there's no point.
So both are talking the same thing.
Perfect. Yeah. Then, because it's just that a reinforcement that we may need, or probably to counsel the patient also, because they always will be asking what is the other evidence, right? So in that sense, we look at it.
Right.
Otherwise, normal functioning ovaries, there's no point doing an AMH at all. Okay. So we do this, then we give them the options, right? Even if you're a low AMH, and as I said, there is something attached to the number of eggs which you're going to get when you're doing an IVF protocol. Every cycle, there is a different number of eggs which come up. For one egg to come up or show up today, it would have traveled at least around 70 to 90 days. Okay, so one small cell to become a visible follicle, it takes around 70 to 80 days. Right. So if I see 3 or 4 follicles now and say, okay, fine, let's start a treatment, it may not be the best.
Right.
Because there are certain medicines, or there are certain treatment, or there are certain therapies which you could use it to increase the number of eggs getting recruited to come into the pool of follicles which develop within another 70-80 days of cycle. Suppose I'm planning an IVF, I would say, okay, fine, we would start the treatment so that your recruitment is better. Because for me, the IVF, when you talk about IVF, other than the age, the numbers matter. Right. So I would rather take you that 70-80 days to get those number of follicles which are healthy enough. So this is how we do. We just, whenever anyone comes with a report, try to, not bother too much about the reports. First, confirm the diagnosis or confirm the report whether it is. Do as minimal investigation as necessary because the modern day ultrasounds and the technology which is used in ultrasound, we could actually see a very good image of ovaries and the uterus. So it's very unlikely that we miss out some major problem in that. So once we know about the number of eggs, then we can plan your treatment. Now we say, okay, your AMH is 0.5 and I'm seeing around 4 or 5 follicles. Then probably yes, you have a chance of normal try for 1 or 2 cycles. IUF for maybe 2 or 3 cycles. If it doesn't work, then yes, IVF is always there. In next 6 months, nothing much is going to change. And we are in touch. We are seeing at least once in 10 days or 15 days, we are looking at your ovaries. So nothing much is going to change. So don't be worried about it.
And I read somewhere that AMH levels are also because of egg quality, not just the ovarian reserve, or because of fatty liver or any metabolic disorders or stress levels, some cases even. So all these also play an important role in hormonal health, overall fertility function. How true is that? Are there any other factors apart from ovarian reserve that are impacting AMH levels?
See, AMH, as I said, it's a marker. It can be affected by liver metabolism per se, fatty patients and things like that, because blood dilutions or a fat, it itself is AMH is a chemical, right? It's not that it is. So there is an interaction. As I already said, if the patient is on some chronic medications or ovarian suppression drugs, she is on autoimmune therapy. We've also seen there is some kind of a correlation between thyroid disorder and the AMH fluctuations. Very high level of anti-thyroid antibodies in the body can also falsely show you that the AMH is on the lower side, or sometimes because the anti-thyroid antibodies are very high in the body, the rate of deterioration of the egg numbers also faster. So we've seen some kind of a correlation, though we cannot still very much pinpoint on it. Thyroid disorder to that of the low AMH is also there. There are many medical conditions which can affect the temporarily affect the AMH value, but we have to, as I said, if you put both your AMH and scan together, probably you will be able to do a better prognostication than the going on one point diagnosis.
When people know that AMH is low, they always Google search what are the food I should eat to improve my AMH. Is it the right approach to think? Because end of the day, they want for healthy pregnancies and outcome. And they are very, very paranoid about how do I improve that level. So what is your take on
improving AMH? Improving AMH. Initially we said that every girl child is born with certain number of on the eggs in her body, and over a period of time there is some amount of depletion, deterioration which keeps happening in it. But I've also told you where the AMH comes from. AMH comes from not the smallest cell, it comes from the intermediate cells. Whereas eggs exist as cells. Initially there are one single cell kind of a cells in the ovary, so they are not secreting your AMH, right? So it's only the medium grade, that is 2 to 4 mm kind of a follicles, or maybe 1 to 4 mm follicle is secreting the AMH. So this is a notion that many people think that my AMH can improve. Yes, it can improve. If the more number of eggs are getting recruited in the system, then your AMH will be shown as your AMH is improved. That's why I said antral follicle count and the volume of the ovary. Because volume means that there are lots of cells which can still become the healthy eggs, right? So yes, there are certain foods, there are certain medications which can improve your AMH, but mind you, AMH improvement is only the number of eggs which have got recruited. It is not again extrapolating that your reserve have improved. Your reserve is the same. Your reserve will depend on your volume of the ovary, your AMH and your antral follicle count, but not that you take certain food and you totally become normal and say, okay, fine, my AMH is all normal. Now I will not bother going to the clinic for another 6 months, year, and then I'll be. No, it's not like that. There are lots of lifestyle changes which can be done by the patients. There are food which can be used. There are medicines which can be given to the patient.
Right.
Minimum 3 months duration. You will see some amount of change.
Yeah.
You will only because there is good number of cells which have got recruited to become a active follicle or a egg.
Right.
Not because there is new eggs which have come. This is something which I keep telling that you cannot have new eggs which will come up. It's eggs which are there which develop.
Right. So when you say this, now I one thing question in my mind, is it even the right problem to worry about? Let's say somebody has low AMH. Is it the right problem? Like, what should I do to improve my AMH? Is it the right problem to think, or they should be thinking about something else?
I would not call it as a problem.
Yeah, I mean,
so I would say when you have an AMH,
it's
what
like,
is the next thing to do or next step to do?
I'll clarify it a little bit. For example,
how do I approach it?
People are thinking like, oh, I got 75 marks in my exam. How can I improve it to 90 or 95? So people are thinking, and if this is magically improving, all my problems are solved. So is it a right way to think? If not, what should I actually think about so that I get a healthy outcome?
I would say rather think about people who have not passed also have become big leaders. And
they made it.
Right? Steve Jobs, he did not even have a proper degree, right? So that's not the way to think, I would rightly say. If you concentrate too much on the AMH, you're only looking at the AMH improvement, decrease, decrease, and then you're so stressed out about it that you are not looking at what is the end point which you need. Do you need AMH or you need a pregnancy? You're looking at a pregnancy, right?
That's right.
Then you look at your lifestyle, what you can change. Because as I said, lifestyle could be a reason where your things are low. Your thyroid may be badly corrected, it's not under control. Your sugars are not controlled. Your lots of other things, diet, eating habits, your stress, all these are not controlled. So if you work on it, probably you will reach to the end result of a pregnancy. Whether AMH in this process improves or not is totally secondary. As I said, we as such do not go and measure AMH again until unless we are forced to by patient insists like, I want to know my AMH. You want to know your AMH? I may do it, but then I don't want to know your AMH. I know your AMH is on the lower side. You started treatment. I am looking at an end point. So
which is pregnancy.
Do not focus yourself so much that my AMH should become normal, then only I'll try for pregnancy.
That's
a wrong thing. You focusing too much on AMH and not doing the right thing is not going to work. So I would say yes, look at the factors which could have caused it. If there are factors which can correct it, correct it so that you can have a healthy lifestyle and probably the pregnancy. But if there isn't any factor, then concentrate on getting the pregnancy. Then looking, my AMH is 0.5. So my quality of the eggs are not good. So the baby which is born out of this is not going to be. You're extrapolating too much.
Right.
You just think, okay, it's 0.5. Have a limited time, probably. Then plan
probably again we don't know what that time is.
We don't know.
Right.
Because as I said, I have a patient who is 0.3 3 years back. Now also it's 0.3. Now what should we do with that?
So can you, just to bring hope in a right way, in a positive way, not in a super optimistic way, can you also talk about in your 2 decades plus of service, you have seen so many people, can you talk about some of them with low AMH reserves where you have taken decisions to encourage them for a natural trial or an IUI without IVF, they found a healthy pregnancy outcome?
See, first thing, nicely framed question. First thing is, we are only instilling confidence in you.
Right.
We are not selling a product. Okay, it's not that you come to us, we'll get you natural pregnancy. No, we're not talking about that.
True.
I'm only trying to tell here in this platform that Do not get into this spiral where AMH is the magical word where we have to talk about, and if that is not there, then it's not. The world is over. What you need to understand that if AMH is certain number, then this is the amount of treatment, or this is the plan which you need to sit down with your doctor and plan that. True. Right, rather than jumping into the last treatment and say, oh, I want to go for IVF. So the thing here is, we are not very here like super optimistic. You will definitely consider. I will put a roadmap to you. I will tell you an instance. I'll give you an example also. We have patient who had undergone IVF, IUI outside, and AMH of 0.2. Right? So this was around 32 years of age, and then all the things were like and tuck, done, and then yes, there she comes and says, I don't have any hope, okay, and I don't want to go through IVF again. Now that was a wrong thing. I don't want to go on IVF. Yes, you don't want to go. That is your personal decision. You need to take it, right? So now we said, okay, fine. If you don't want to go through IVF, yes, you can still try normal because you're still producing eggs. Right. So these are the things which you can do for your lifestyle and try. And she tried for 3 months. She did not conceive. And then we said, okay, you're not conceived. You have another option where you can think about IUI before thinking of IVF. She said, I still don't want to go for IVF. If you want to do IUI, do IUI. First cycle IUI didn't come positive. Second cycle IUI did not come positive. She said, see, listen, I have already lost hope on this. As we said, okay, last cycle you do, we'll see. If it doesn't, then you will just leave it alone. Fortunately, she conceived in the last cycle. So that happened. So this is something which we will say, okay, fine. Because I said right egg, right sperm, probably it clicked. It's not that we did anything. It's a right egg, right sperm, and things work like that. There was one other patient who has undergone surgery for endometriosis. Now they came for with us telling there is a 4 centimeter endometrioma, AMH of 0.5. One doctor has suggested IVF, another doctor has suggested surgery. Because there are lots of confusion regarding how endometriosis has to be managed to that of an IVF. Now, our dictum, if you already got operated once for an endometriosis and you're still thinking about pregnancy, no surgery. We would not say another surgery on your ovary. We would rather do an IVF or whatever. So this patient was in like, should I go for IVF or should I go for surgery? My question was, have you tried normally? No, we've not tried. The first time I went there, doctor did a scan. He said there is an endometrioma. They operated. Now they are telling AMH is low. And now I thought, okay, I can take some time. Now one more endometrioma has come. What do I do? I said, go try normally. Fortunately, she conceived. Wow. But unfortunately, there are some more people who have not conceived. They're there. Yes. For the not conceived one, there's one patient where we were diagnosed with endometriosis. We tried normal, did not conceive. We went ahead, did the surgery, removed the endometriomas, removed all the adhesions, then put her on normal treatment. IUI did not conceive. Then we had to do IVF. Okay. But again with an IVF, we said, okay, because you are at the age of 36 years of age, then we would suggest you genetic testing. She was very happy about going for a genetic testing. We did genetic testing. Out of 8 embryos, we got only 3 which were genetically good. We put 1, she conceived. Now she is telling, I have 2 more babies in your lab. I said, no, there are still embryos. When they deliver, then only we'll call them as a baby. So we still have 2 embryos. So there are different stories. We need to be patient. We need to believe the process. It goes in. And no time we say, okay, see, listen, this is the end of it.
True. Yeah. I'm very glad that doctors like you are a boon to the society, that those folks got a good informed decision making. On that note, I request you to share few suggestions when somebody has a low AMH levels and doctor is recommending for an IVF treatment. What questions they should ask their doctor, or what should they understand so that they take the informed right decision for themselves.
Okay, so the first thing when the AMH test has been done, so as I said, first thing you need to ask is what is my antral follicle count and how do you balance these two? How these two correlate? Suppose there is a low AMH and a good number of antral count, then probably there's something wrong there. There is a good AMH and a less antral count. That was also wrong. So you need to ask your doctor, how do you correlate these two results? One.
So that conclusively we know that egg reserve is less.
Yes.
Okay.
Yeah. There is some problem with the egg reserve. I would not say less or high. I would say there is some problem with that.
And next, that follicular count you said is by AFC scan.
Follicular count, antral follicle count is by transvaginal scan. Transvaginal.
So tally
both of them. Next question is, why is my AMH low? That should always be some question which, though we have seen that many times we are not able to answer. If there is a fixable reason, if we could fix that, and look at it, like endometriosis, there is a PID, there is some kind of a autoimmune condition, then we know that okay, this is gonna eat away our ovaries faster. So then we need to go to the next level treatment. Next question is, what our patient should ask is what are the treatment options? Do not fall to the trap telling that IVF is the only option. What are the treatment options? What if I try normal? What if I try IUI? What if I try IVF? So what is the things which can happen? So you need to have, there are a certain number of success associated with each of it. You fix the numbers. Next comes is, if you are suggested IVF, then the question which you need to ask is, how sure are you that this can work for us? And what are the protocols which you're going to use to make sure that we get a good number of eggs or the oocytes or the embryos which you could create out of it? Because it's not like fast food kind of an approach. One thing serves all. For us, it's individualization of the plan here, because you're 35 years of age, your AMH is 0.4 or 0.5, and I see around 3 or 4 eggs when I do a scan, then I need to tell you what I expect out of these eggs. What is the embryo? Now you have AMH of 0.5 and I see around 6 to 7 follicles and you're only 25. Then I can tell, okay, this is this. Then I can get the pregnancy in first cycle. So it's an individualized approach. So you need to ask as to what is that your plan for me. Because in one cycle it may not happen. In 2 cycles it may happen, or 3 cycles it may happen. So how are you telling, going to manage my 2 to 3 cycles of stims, and what is my expectation out of IVF? So these are few questions which they need to, keep in mind and ask. And there's no harm in taking one more opinion on it, because there's nothing wrong in it. Probably because I would say, there is always a chance that someone gives you another opinion. So then you sit back and evaluate. Always, it's better that couples sit back and evaluate themselves as to on what suggestions they have done. Taking the fear factor out. That's one thing which I don't know how do we take that out. But then yes, fear is something they should be out of it and take a decision.
In your practice, you take the help of nutrition coaches and also Ayurvedic doctors. Like right here, Dr. Aksha sits. Why? I mean, very few allopathics do that. Why you take the help of alternate medicine as well? And how it helped in your practice in general, and also the couples who are visiting you?
Well, we've actually divided the system of practice of medicine in homeopathy, allopathy, Ayurveda. If you look at the Indian system of medicine, I think Ayurveda is there for centuries together, maybe. We, as such, what we wanted to try out, imbibe in our patient is, there are lots of factors which science is still not able to answer. Maybe in future we will have an answer. But when you look at the core sense of how any human development or the genesis and things go on, lots has been related to what you eat, what you breathe, and how you practice your life, right? And Ayurveda, in sense, has looked into the nature and used it for us to propagate the life. So this was what happening. If you look at, I think the way back story of Ramayana, Dasharatha was given some kind of a concoction which he took it to his wife and gave, and then she conceived. That was then we would say probably he gave him clomiphene citrate or letrozole. Probably that's what resulted in ovulation induction. So in nature there are lots of things which can be used to modify our system to help the fertility to happen. So we were trying to see if we can coexist in sense allopathy and the Ayurveda. What we thought, after a prolonged discussion and thought about it, there's the lifestyle modification, the stress management, your diet is very nicely managed in Ayurveda. Whereas the rest of it, like follicular tracking, follicular monitoring, fibroid management, endometriosis management, some of the things is good with allopathy. So when we integrate both, then the result comes. We have seen it to be a very good kind of an outcome. Patient is happy internally because they are going through the cleansing process. They are getting the advantage of both the system in under one roof. And mind you, Ayurveda actually doesn't cost really much. But if I say a patient, go get yourself done, weight loss program done, going on a crash diet and things like that, may not be healthy. But in an Ayurvedic way, it is healthy, and we are not. And most of the Ayurvedic consultants who work with us are certified in Stri Roga and fertility management. So there is huge scope of this kind of a collaboration, which would restore the normal health and also the chance of normal conception.
It's not just about curing the sickness, but also creating health. So you have integrated both.
Another place I've also found it to be really helpful is because many of our patients are above 35 years of age, the pregnancy outcomes like preterm deliveries and pregnancy induced hypertension, IUGR, all these are quite a high thing. But with Ayurvedic doctor coming in with our thing, and with their diet and all, whatever they do, I do not know. I have actually not stepped into your cabins and seen what they do, but then it's really helped. It's really helped. Because in our system, as per se, we give so many medications, but along with the positive reinforcement coming through with your diet and your exercise and yoga, breathing, meditation, it's actually helped a lot of our patients carry their pregnancy to a very larger term, and the baby weights being good. It's good. So I think there is a good scope. Probably we should come out with some kind of studies and publish it and things. Let's see how it happens.
I think it's a long way. I mean, especially work is not being done in mainstream, but now doctors like you are encouraging the coexistence. I'm sure it will reach more audience and studies also will come. But before they come, I want to take some anecdotal observation from you. So when you integrated both of these, life sciences under a single roof, can you at least share one example where you saw wonderful results? And if a standalone allopathy practice or a standalone Ayurvedic practice try to handle that couple, probably the results would not have been that fruitful. So anything.
See how we came through this is, I'll tell you, because we being in this part of Bangalore, we are surrounded by lots of Ayurvedic doctors, and I have a center which is in Kanakpura Road, and Sri Sri Ayurveda Center is close by. We used to get patients from there, couples coming and telling, they are doing this and I'm not understanding what's happening in my internal system. What can you, do? So, we used to do scans, blood tests, start them on treatment. But there was a discord, what they are doing or what we are doing, and the patient was in between, not understanding what was happening. So when we sat down and discussed with some of our Ayurvedic friends, most of the time there is no conflict of the treatment. Only thing is, how long do we wait in a Ayurvedic process to wait for the pregnancy to happen was always a question. I've been taking it for years together now and things have not worked. So this is where people tend to lose faith in the system. See, even in allopathic system, there are some patients who have been going through for years and years together, but we have some evidences, we work with the evidences, but whereas Ayurveda, there's not much of an evidence which you could show, probably only the patient testimonials are there. That's when we thought that if the collaboration happens, patient would get benefit of both the worlds, and it's just about the collaboration, as I said. How long do we wait? Our discussions with when we sit down with our patient our history, we discuss as to how long do we wait, what kind of a protocol Ayurvedic doctors are going to put, and is there any cross reaction which can happen with our medicines, and then at what juncture do we think we need to advise them IUI or an IVF. So when patient understand the whole protocol, and then there is no kind of a conflict between us. And one thing which we always believed is do no harm. So when no harm is done with both the sides, then the results are beautiful. We have had quite number of patients, particularly on the obese sides. We had on this patient was 38-year-old with BMI of almost 28. And she was struggling with her borderline sugars, and HbA1c was high. So we were all the time trying as to put her on more and more medicines, and we had to go on to the insulin. And then when we had a discussion with Ayurvedic people, they put them on diet, yoga, and it's stringently followed up. And that following up is a big reinforcement again, because what I feel is many a times patients are tired of you can do it kind of a thing. But when you get a positive reinforcement, it makes a difference in. So she lost quite a bit of weight. Her sugars came under control. We had to let go of insulin, and then just diet modification and exercise and certain medicines worked, and luckily she conceived. So this is the miracle, because I would not say miracle, it's a collaboration. Miracle or a magician is also about the collaboration of technique and skills. In similar way, when there is so much of positive reinforcement coming in, you know that back home also you can do something to improve it. How you breathe, you can make a difference. So these are small lifestyle changes which is reinforced by our doctors here, is making a huge difference.
So wish many people implement the collaborative protocols that you're doing to make better place. And I'm really glad that I also got to know about your work, and we started this fertility center, and combining help of both the worlds to give best outcomes. And in fact, I personally wish more and more centers follow these collaborative protocols.
Actually, I'll tell you what is the point, stress point here is. We are all now getting used to what is this called as fast food kind of a culture. I go, I get a fix.
Pill culture,
I get a fix.
Right?
I get a fix.
I get this.
I don't have a time to wait. But you understand, you go to some hotels or cuisines or places where you will be made to wait for 15-20 minutes or half an hour, and food is excellent. It's tailored to your taste, it's tailored to so people do appreciate that. But for most of the time in the health sector, what we've seen is they want a quick fix. When you talk about quick fix, that's where the things are going wrong. We need to understand what you need. We need to then plan it accordingly. We have to have our allopathy, we have to have our Ayurveda, you need to change your lifestyle, all those things. Why should I do all those things? Why should I go through all these things? Jaldi kar do. Quick fix it. So that's when things go wrong. So I sometimes start this way also my patient. If you are patient enough to wait and take our treatment, please come to us. Or you think you can get a quick fix done somewhere else, we are not the place.
Sometimes quick fixes can be costly.
Quick fixes are usually costly
on the body.
Of course. All
right. one last question which I would like to ask. There are many things, some things going right, some things going wrong when we are dealing with fertility health as a whole. I want your opinion on, from the couple side, what are going wrong, like from their thought process. One thing you pointed out, quick fix.
Yeah.
So like that, from the couple side, what they're thinking wrong according to you, probably how they could have thought better, and from the consultant's point of view also, from the system point of view also, what probably are going wrong.
Okay. As I said, one was this quick fix where people want it. So if you have a quick fix, then there are lots of solutions. Also, there will be lots of places which will come up and give you quick fix, and that's how many times the exploitations of the system happens. One.
Sorry, can you repeat? I didn't get it. What lot of PSS?
No, lots of other. See, when you want a quick fix, there are a lot of other places also which will come do a quick fix. So like now my demand is I just want to go have a quick snack. I can drop down to the whatever the fast food restaurant. I can get it done. It's fine. So your demand is there. So there will be a demand. The place which will cater to your demand. Then the whole chain falls off and things go on. As far as the patients, what I want them to understand is nature is very perfect in sense how it is adapting, how it is controlling the system. When you talk about cycle to cycle or fecundity, what we call, the success of pregnancy is worse than the UPSC results. Okay, it's like 5 to 8% is your chance of succeeding in 1 month. Even when everything is normal, you are the healthiest couple on the earth, that's the success which you can get, right? That's why we say try for 12 months. But what happens? My peer pressure, my family is telling you have wasted 3 months, you have not got conceived. The one who got married with you has conceived, you have not conceived. All those things will start. So that pressure, you need to, I do not know, maybe whole society needs to understand this, that there is a system, it takes care of it. And now question is why it's only 5 to 6%? Because nature has devised things in such a way that something which is very unhealthy should not be coming. Probably fertility is happening, but then if it is not a healthy embryo or a healthy pregnancy to implant, may not implant. Then that's something which everyone has to understand, that your success is only this much. Now, many of this couple come to us and ask like, what is that we can do to improve this? Now, when I said nature itself has decided to be that way, then you cannot. Yes, we can give you some pills, tablets, medicines to improve, but then this will also has some amount of side effects. That's when we have started seeing more number of multiple pregnancies, twins, triplets, all this happening, or abortions, unhealthy pregnancies. So those things also come. So give nature its own time. Take your own time, and then help it. Next is the stress level which this couples come with. One is the peer pressure, one is the time pressure, career pressure, whatever pressure. It's all in the pressure cooker only when it comes. So if you can work on your pressure and you can understand what you could handle, how you treat this in a huge way, because I'll tell you, almost like 40 to 50% of our investigations yield just no result, in sense that it is called as unexplained. So most of these unexplained are related to your lifestyle, your stress factors, and probably some unknown factors which we probably you need to probably address all these things. I think, and yes, whether AMH we have been discussing. One more thing about the nature. Now you said we were always talking about the low AMH. There is a high AMH also. When there is very high AMH, we call them polycystic. So that doesn't mean you are endless reserves. They are also going to exhaust someday. So when what is the correlation between AMH and AFC? We've been talking about it. Nature is also beautifully designed in such a way that if your AMH is low, I'm going to keep sending eggs which in a lesser number of eggs.
Nature is
trying to protect. Exact word. And the resource management. It knows it's resource management. It knows that I cannot send out a whole lot of eggs and I will be exhausted. So If your AMH is 0.3, maybe 1 or 2 eggs are developing and coming every cycles. When it is going to end, as I said, we can never know because nature knows its own way to control things. Anyone with a lower AMH should not get scared, oh, it's going to get over in next day or two, because nature has decided in way. Until unless there is some other added factors which are causing the reduction in the AMH levels. I think
so couple should focus on their lifestyle. Of course. Understand that the chances of conceiving in the first month itself are quite less, so don't worry for a year.
Of course.
Third, don't worry too much about your AMH, and peer pressure. Timelines are different for each of them, so understanding, and not go for quick fixes.
Never go for quick fix, and don't try to understand your condition putting your data onto the Google or a
chat GPT,
and say, oh wow, this is my score.
Right.
Absolutely.
So there is no fertility index,
because I think many would have done this. What is my chance of the conceiving? What's my chance of conceiving like this? Again, even you go on to any competitive exams, you can put your details and say, what is my chance of conceiving? It will tell. 1 in 10, 1 in 20, 1 in 30, 1 in 40. It may tell you, but then you are the one or not. Who knows? Right? So, as far as nature is concerned, please don't try this things. And I think even whatever the data we have, whatever the system like we are putting into AIs and things like that, it's a very long way for us to come up to a conclusion as to which month this couple will conceive. I think it's going to take another 15-20 years for us to say, okay, this is the month they're going to conceive. Because in spite of having good embryos in our hand, in a ready product, we're still not able to break that code that this embryo is going to become next Einstein.
Right. Very true. In fact, you're talking about AI in the future. I was recently watching an interview of NVIDIA CEO. He's like who's who of AI research. When asked, he said one beautiful thing: AI can do everything humans are doing, but not at this precision.
Correct.
Maybe 30-40%. So you use AI for that 30-40%, and maybe that might increase by 10%, 20%, but it can never replace
Exactly.
Humans who are using AI can take.
No, I would say, there are certain things where we can use this to probably calculate the dose of medicine. Calculate what is the type of calories you need, what is the type of this. We can use all those things. But to calculate the probability of, your 0.5 AMH is going to result in pregnancy in this month, in this way,
I think
is still a very long way. I'm not sure that even AI can break that. But if it happens, I'll be, very happy about it.
Now, what on the other side, on the care provider side, what do you think are the major patterns that you don't agree with, or you think could be better?
Care provider side, if I look, the whole journey of fertility has suddenly catapulted in a level where it's become a business. Even if you look at the Times or Economic Times, which was recently, I think last month or so, has quoted it's a $1 trillion business or $1 billion. I'm not sure the numbers, but you're looking at a business now. Okay, so when there is business, there is money. When there is money, then obviously there is lots of
decisions will be biased.
Decisions will be biased. So that is what has changed this whole care provider thing, because we are looking at fertility as more of a business oriented. So when my business oriented, if sorry to tell, if everything happens very smoothly and naturally, then probably the business is not really great. But if we promote more IVF, if you look at, actually there are lots of centers, they do not tell it is a fertility center. They only say it is IVF center. So when you get into an IVF center, you cannot expect them to talk about fertility. You are expecting them to only talk about IVF.
Trial, there is no discussion.
Obviously.
IUI, there is no discussion.
Obviously.
Only
So,
IVF.
You are walking into a specialty diamond store. You are walking into a specialty diamond. You cannot be asking me, show me some kind of a silver jewelries or golden jewelries, right? So you're asking for it. So when you walk into so that's the way it works. So I have no other much option. I can only talk about what are the different types of IVF I can. So that's what has happened in the care provider center. And as I said, there are rules which have changed a lot in Indian ART law, which has changed, which has actually to a large extent controlled the way this whole of this IVF treatment centers or clinics were increasing. But there is still a long way to do a work on it. Yeah, there are lots of rules which have come in because of new ART rules. So there is a stringent way they are monitoring the consultants or the people who are doing this IVF treatment. But still, we have to look at more experience in this field. I have seen that lots of young consultants who have been coming. They're good. They're really, many of them really good, but experience goes in a long way to teach. So I think there is a lack of knowledge and experience which needs to be still developed.
Right.
Yes, patients as such, awareness, whether it is a lack from the care provider or whether it's the understanding of the patients, we do see that there is lots of gap in that which is not getting fixed. Probably, as I said, quick fix ho raha hai to wo kar lete hain. Why should we waste our time and things, understand it. Whatever said and done, IVF has a history of 4 decades now because of the treatment medicines. Right. We still do not know how long or what impact it is going to have in the life. There are some papers coming in telling about genetic changes, which you call it as epigenetic changes, which are kind of coming in because of so much of artificial manipulation. Though they are very, very less in number, but we do not know how it's going to accumulate. The data may accumulate. So this is from the care provider side. So
right. Sir, one thing that egg explanation, shall we take it again?
Tell me.
So
AMH lower the number of
nobody can know how many eggs are there.
Fine. Okay.
I'll ask a question. Can someone know how many eggs they have and how many months or years they have for fertility? Then you can explain like that's a box. You can just understand whether egg reserve is depleting or not. We can't find that. So AMH is one proxy, but AMH should be validated with AFC count. That's it. Can a couple trying to conceive, can they know how much time they have till their eggs last? Because they say every female partner, every woman is born with fixed number of eggs. Is there any way to know how many eggs are there and how many months she can be fertile?
Well, this is again very question. How do I answer? It's a very rhetorical question, I would say.
But as a couple, this comes very naturally.
This is very natural. See, whenever you're going to when you take your child for an admission to a school, first thing you'll ask is, what's the chance that he will, become 99% in 10th standard? So first standard you're admitting, asking the question.
Asking for that, and also
it's something like
it's more like today's generation want to know after 10 years will I be fertile or not? I don't want to, or I want to have a second child when I feel more financially stable after 10 years. I'm 13 now already. So to
is
there
answer
any
that,
magical?
We do not have any dynamic testing. We only have what is called a static testing. Static testing is, I am doing a scan, so we know that this many number of eggs are there. So this is the volume of the ovary. So this is the chance that
current cycle. Current cycle.
If when you talk about antral follicle count, that is for current cycle, and the next 1 or 2 cycles that may be the numbers which are there.
But nothing to find out the number of eggs overall somebody is born.
That's when how many eggs you're born with you can't find out. AMH is a surrogate marker to say you have a good reserve, but it doesn't say how long it's going to last.
Right.
Until unless there is any life-turning changes which happen like surgeries or trauma or probably an infection or autoimmune disorder, this has got a very steady kind of a decline at a very nominal rate. If you're 3 AMH at 1 year, it's not going to become 2 next year. Maybe it will become 2.9 or 2.95, something like that. So that is the rate of deterioration. Because as I said, nature has designed it really very well. In sense, you need only this many eggs to go out. So we will develop only this many eggs. So that's why I say when you're counting not just the AFC, you also look at the volume of the ovary. So that would talk about number of eggs in that box. Because the cells are the eggs are very minute cells which need to develop to become a follicle and then an egg. So these are in a reserve, right? So when I do a scan and if I see only 2 or 3 follicles, then I know, okay, the AMH is low. That's why less number of follicles are coming in. Okay.
Right.
So this may not end soon.
Right.
It will take longer. Okay. It may take some more time, but we need to use this gap of time to make sure that she conceives. There are no tests which will say, okay, at age of 25, your count reserve is this. At 30 years, this will be yours. I cannot write and say, okay, this will be your AMH. Your AMH is 3 now. At age of after 5 years, it will be 2.5 now.
And so that also depends on what lifestyle and everything they are going through in that next 5-10 years.
Absolutely. And plus the pollution, nanoparticles, nanoplastics, blah blah. It's all in our system.
I mean, there are so many things surrounding to harm us than help us.
Recently, I think it's just among ourselves we were joking, things like that. Like blood group A positive, B positive, and all. Later on they'll say plastic positive also.
Oh my God!
There is so much of nanoparticles,
microplastics around. Yeah.
So we cannot predict that journey.
Right.
So you need to be cautious because one thing is that in nature we've seen that nature only things about propagation and going further. I was recently hearing to this Naval Ravikant's thing. He says like that the only injustice or only thing which we can in this generation we can do is stop the generation from propagating. That's a very nice thing because that's how the humans or any animal is programmed to be. Now you decide to not to promote your procreate. That's the biggest injustice you can do to the nature, right? So something like that. But then now we are seeing that even procreation is becoming so difficult. Do not, my humble request to everyone who is listening is, do not try to predict your fertility future or on certain numbers and some things. Try to be very practical enough to balance both.
Yeah. On this, now I got one question. So let's say someone has low AMH levels and they did they did transvaginal scan and found out follicles to be low in number as well. So it's matching. So overall egg reserve is low.
Correct.
Then how soon, that question they can't answer. Is
no.
that?
Yes.
How
yes.
soon it's going to contain?
No, they can't.
But it will never be like super immediately in the next 4 or 5 months.
No.
Your egg's going to stop coming out. Nothing like that.
No.
Okay.
We have not seen that situation happen.
No.
At least in last 10-15 years of I've been doing actively in the IVF field. Even if your AMH is 0.1, we've been seeing 1 follicle. It's coming. I was like, when are you stopping? It's not stopping. It's going on. So
till menopause,
it goes on. So when it is going to happen,
nobody can. And we just need one single healthy egg to conceive naturally.
Of course. We need one single egg, but plenty millions of sperms.
Yes.
Of course, yeah.
All right. So this has been very insightful. I think these things couples should know so that they can take better informed decision and also work on their lifestyle. I'm sure people who are watching this, it's very, very insightful. And I should thank you for all the service you are doing to the society. I am pleasure to be associated.
No, I'm not doing any service. I'm just doing what is right, I feel. That's all. Because, I've not gone out of my way to do anything really that much. Hope, because this is something which is quite in Western, informed decision.
Yeah.
You can make an informed decision only if you get all the information.
Exactly.
Right? So I think the first thing which couple should do is to try to get as much information from the
In the right
doctors and
direction.
a doctor's perspective, not to just go on to the Googles and chat GPTs and things. Though I'm also happy to answer those kind of questions, but sometimes it is really difficult to answer all the questions. But putting do not try to, another thing which they keep doing is that couple happened, this couple this happened, that couple this happened.
Right.
You are unique by yourself.
Right.
So you collect your information, take your decisions.
Yeah. I think that's a beautiful line. Thank you so much for this. This is super enlightening. Thank you so much.
Thank you.
for doing
Thank
this.
you. Thank you.